The paravertebral block is used to provide postoperative pain relief after surgeries involving the thorax. This includes breast surgery, lobectomy, or pneumonectomy. This procedure can also be used for pain management in patients suffering from rib fractures or flail chest. The equipment required to perform this procedure includes a nerve stimulator and electrode, an 18-gauge TUI needle, a 10 milliliter syringe filled with the local anesthetic of your choice, a loss of resistance syringe, a 5 milliliter syringe with 25-gauge 1.5-inch needle, 1% lidocaine, and a 20-gauge catheter appropriate for nerve stimulation. A sterile prep solution, for example povidone iodine, a marking pen, a sterile fenestrated drape, and a tegaderm dressing are also needed. The patient should be placed in the lateral decubitus or sitting position. If in a sitting position, ask the patient to touch his or her chin to the chest, allow the shoulders to droop, and arch the back toward the physician. Rest the patient's feet upon a footstool. This increases the degree of kyphosis in the back and increases the space between the transverse processes, allowing easier needle placement. Identify and mark the thoracic vertebral interspaces. The T7 vertebra typically aligns with the tip of the scapula. Starting at this level, palpate the vertebral body superior to this point until you have located T7 through T4. Typically, the T4 interspace is used for a paravertebral block placed for breast surgery. The T7 interspace is suggested for thoracic surgery. Similarly, if the patient is in the lateral decubitus position, you will also need to palpate and mark the appropriate thoracic vertebrae. Mark the needle insertion site 2.5 to 3 centimeters lateral to the spinal midline. After identifying the appropriate vertebral interspace, prep and drape the patient's back in sterile fashion. Using a 25-gauge needle, aspirate the syringe and inject 2 milliliters of 1% lidocaine into the subcutaneous tissue of the vertebral interspace. Change the needle to a longer 1.5-inch needle to anesthetize deeper tissues. As you inject medication, use the needle as a finder needle to identify the bony vertebral landmarks of the thoracic spine. Insert the 18-gauge TUI needle through the cutaneous skin wheel. Hold the TUI needle hub to control the rate of insertion. Attach the nerve stimulator and continue to advance the needle slowly. Insert the needle tip perpendicular to the skin surface and direct the tip toward the transverse process, as previously identified by the finder needle. The depth of insertion to the transverse process is typically 4 to 5 centimeters from the skin surface. Note the distance marking on the TUI needle at the point it comes into contact with the bony transverse process. Because the paravertebral space is located 1 to 1.5 centimeters deep to the transverse process, using the original distance of needle insertion will aid you in finding the paravertebral space and will help to prevent needle entry into the pleural cavity. When the needle contacts the bony transverse process, remove the stylet. Attach a loss of resistance syringe to the needle and redirect the tip 10 degrees superior to the original path of insertion to walk off the surface of the bone. Advance the needle an additional 1 to 1.5 centimeters to enter the paravertebral space. Easy injection of the air indicates loss of resistance. The needle has passed through the superior costotransverse ligament. Using saline to test for loss of resistance should be avoided if nerve stimulation is to be used. saline conducts electricity and thus precludes the use of nerve stimulation, D5W provides a marked sensation of loss of resistance and preserves your ability to test needle placement with nerve stimulation. Although nerve stimulation is not required to confirm needle placement, it may be used to substantiate the needle's location prior to the injection of anesthetic. The nerve stimulator should be set to 2 milliamps. If appropriately placed, the stimulator will generate sustained twitching of the ipsilateral intercostal muscles. With the needle correctly located, attach the anesthetic-filled syringe to the TUI needle. Aspirate the syringe to ensure that the tip is not located within a vascular structure. Inject 3 to 5 milliliters of local anesthetic through the TUI needle. Withdraw the needle and syringe together in a single movement. Cover the insertion site with clean gauze and a bandage. If the patient is likely to experience continued pain, a paravertebral catheter may be indicated. An appropriate catheter is attached to a nerve stimulator, and the opposite end is inserted through the TUI needle barrel. Gently thread the catheter through the needle. The catheter should not be advanced against resistance. The catheter will generate sustained twitching of the ipsilateral intercostal muscles as it is inserted. If the intercostal muscles cease to twitch during catheter advancement, the needle needs to be adjusted to correct the catheter location. Although there is controversy about advancing and withdrawing the catheter through the TUI needle tip, this method can be used to assist paravertebral catheter placement. Withdraw the catheter tip into the needle barrel and rotate the TUI 45 degrees clockwise. Re-advance the catheter, looking for intercostal muscle stimulation. When muscle stimulation is sustained with catheter advancement, the catheter is correctly located. With the catheter suitably positioned, carefully remove the TUI needle over the catheter, holding the catheter in place. Although not required, the catheter can be tunneled in the subcutaneous tissue to prevent dislodgement. More frequently, the catheter is secured with benzoin and a tegaderm. A Luer lock or connector is placed on the end of the catheter to prevent contamination. A test dose of lidocaine with epinephrine, 1 to 200,000, is given to the patient. Warn the patient of symptoms that may be experienced if the catheter were to be located within the intravascular space. Monitor the heart rate and blood pressure for increases that would indicate intravascular catheter placement. If a catheter was placed, loop the catheter and cover it with a tegaderm. Label the catheter as a paravertebral line. Assess the degree of anesthetic dispersion by performing a neurologic exam of the sensory nerves of the thorax. Although the risk of causing a pneumothorax by performing this procedure is quite low, monitor the patient closely over the next 30 minutes for symptoms of cough, shortness of breath, or sharp chest pain. Should the patient experience any of these, an urgent chest X-ray should be obtained. In addition, hypotension may result from the sympathectomy caused by the local anesthetic.